vouch for that.
That's good. Glad to hear it. Well, that'll be interesting to see.
Well,
it will
it'll
be.
turn out good. The surgery wasn't the easiest surgery.
It wasn't?
I remember. Well, not that anything went bad, but it's good to see something that's doesn't gloss over things. So I just remember trying to get your eye in the right position. It's been, gosh, when did we do that?
Oh,
Last
6,
fall.
8 months
Okay.
or 12 months
But-
ago. Yeah, it's been.
Surgically, everything went fine, but
Well, yeah, and
as a
my
surgeon,
vision-
you want it to look perfect
my
when it's on
vis-
TV. of course.
It's really amazing to be able to open your eyes at night and look at the clock and see what time it is. Some of us were blind our whole lives, and cataract lens implants have been a wonderful thing. And but that's not why we did it. It was clouding over,
Right.
partly because of the previous surgery I'd had on the vitreous.
Right, and when you've had the vitrectomy with the gas bubble, and I don't know how much the listeners know of your history, but that can make you get a cataract faster, and that's thanks to the retinal surgeons. So, but then the good thing, the cataract surgery nowadays, it's easy to go through. It works very well. The technology is phenomenal.
And it's great to have a great surgeon.
Well, thanks for saying
And
that.
so, and it's true. And so I'm blessed because I do now see, and I know that things can go wrong, and things commonly, people lose their vision as they get older, and that's a reality. Sorry. And
just,
so,
just like other tissues in the body, things change with age, with the eyes too.
And so let's talk about all things eye. Today with Ken, we've got Dr. Knudsen here with us, and we invite your questions. And we want to take a little break here. Is that right, Jonah? Are we
That's absolutely right. We'll take a break. I hope you listen to the following message, and we'll be back right after these words.
Sure. Okay.
I didn't get a chance to tell you, the microphones are directional,
Okay.
so when you turn this way,
You're not gonna
you
be,
can talk to
Kinda.
him, but if you sit back and away from it,
Yeah.
it doesn't work as well. So you can just ignore him and answer talk to the mic.
Yeah.
But if you're about a fist away from the mic,
You'll be
that's a
okay.
good way to go.
Okay.
Yeah. It was a pleasure to meet you. Glad to
Thank
have
you
you
for
here.
coming, Ken. I know
I
this
hear
is
you
an-
guys.
You do?
Yeah.
Okay. Good.
Usually I'm working, but.
3, 2, 1, we're back.
Hi, welcome back to Prairie Doc Radio. We're happy to have you listening today. Dr. Holm is here, and with him is our guest, Dr. Ken Knudsen, who's an ophthalmologist with the Brookings Health System's Yorkshire Eye Clinic, and also Dr. Hogan's personal eye surgeon.
Yes, Dr.
Dr.
Hogan.
Hogan, oh my goodness.
Dr.
Not Dr. Hogan.
Hogan's Heroes.
Hogan's Heroes. Dr. Holmes. Hogan was on my mind. Dr. Holmes.
Yes, there we go. So let's talk about a variety of different eye issues. I mean, we can talk about macular degeneration, which is a real deal for a lot of people who are listening, perhaps. We can talk about glaucoma, which is sort of the silent blindness causer. We can talk about cataracts. We can talk about let's just go. Where would you like to start? What is the most common thing that you see in your office?
Probably cataracts. Over the years, I've kind of come to call the major things we see the big four. That's just my own nomenclature, but cataracts, glaucoma, macular degeneration, and diabetes. Those are probably the four main medical eye things we handle.
Right, and I get reports from you in your office all the time about my diabetic patients that I'm caring for. And I'm always happy to see the checkbox that says no evidence of a loss of vision associated with diabetes, but you don't always see that.
No, and as your diabetic patients know, the primary care physicians that's one of their main pushes the last decade or so is to get those patients in for their yearly eye exams.
Right.
Because staying on top of it is so important.
So what a lot of the things that happens with diabetes is they have a blood vessel diseases that break, and then you have well, explain it to me.
Well, yeah, essentially the high sugars can affect the health of those small blood vessels in the retina, and you can get leaky blood vessels. This is how I describe it to the patients. You can leak fluid, You can leak hemorrhage or blood, and you can also get these little microaneurysms. They look like little red dots. They're basically small aneurysms on those capillaries, and just when a little microaneurysm or it's a little ballooning there, it stretches the walls of the vessel so they become more leaky. If we see leakage of a certain extent and close enough to the center of vision, then we'll sometimes laser that to help dry it up and prevent further problems.
There's a little welding, spot welding kind of a thing, right? Where you take your laser and you just kind of spot weld right there where the leaky vessel is, and those little dot hemorrhage or aneurysms, you do those too?
Right. If they're leaking, you can. We use a green laser, is what it is, and that does technically little burns. I mean, we're talking very mild, of course, but it helps seals up those leaky blood vessels. And that's what we call background diabetic retinopathy with just these leaky vessels. There's something a little more serious called proliferative diabetic retinopathy, and that's where you start to see new blood vessels growing out of the retina. They look like little nets of blood vessels, and those can break and bleed and cause a vitreous hemorrhage into the cavity back there. If you start to see some of those new blood vessels, then we'll do a different type of laser. It's still the green laser, but you'll actually target the peripheral retina, where you may put 1,000 shots in the peripheral retina, and that actually, it's sounds barbaric, but it actually kind of kills off an area of the retina where you don't really see, you
Much,
don't need
yeah,
that. But if you reduce the ischemic load, then you'll see these blood vessels regress. What's happening, we think, is in diabetes, the retina is starting to say, I'm not getting enough oxygen. It sends out signals to grow these new blood vessels. So by essentially killing off part of the retina, you reduce that ischemic load and they regress and cause less problems.
Wow. I mean, I didn't realize that you did that. I mean,
Yeah.
that's very interesting.
Not as common as the first laser we discussed.
The laser that I remember when it came out, it was after my dad had a detached retina.
Mhm.
And he ended up at the University of Minnesota, and they went in and they reattached it, and then they subsequently put him at bed rest for 2 or 3 weeks.
Wow.
I mean, it's an awful experience for him, I'm sure. And then not long afterwards, and he told me about it, they started with the spot welding of the laser to hold, if you can push that retina back and then spot weld it, then it doesn't detach.
Right.
How many
it kinda
years ago
scars
was
it down.
that?
God, it must have been in the, I was in med school, so it was
Laser was being
70s.
done then?
No, the welding started in the 80s, I
It
think.
did.
But
Wow.
my dad must have. I graduated from med school in '75, and it was probably '73, '74, something like that.
And he had laser work done then?
He didn't have laser then.
Oh, well,
He
you
learned.
said that they
He
spot.
did the old one, and then it was
Oh,
after that he
I
learned
see.
about it, and I was very. I'm thinking, okay, like father, like son. I'm gonna have a detached retina. Isn't it nice? I'm not gonna have to lay with sandbags against my head, listening to a radio you borrowed from your son for 2 weeks,
Doing nothing.
Not
doing
fun,
nothing.
not
It was.
fun.
He couldn't do anything. He couldn't watch TV. He
Well,
just-
laser has to have made a huge difference in your practice, Dr. Knudsen.
Well, it has, and as Rick was mentioning, for retinal problems, it certainly has. And he was talking about retinal detachments, which is a little different than diabetes. There's if you have a retinal detachment, usually then you'll be seeing a retinal specialist, and we have some of those in Sioux Falls that we regularly use. And they can do some surgeries along with laser to reattach the retina. Probably the main surgery for many years was a scleral buckle, where they would actually indent the side of the eye with a silicone band and then reattach the retina by using some cryo probe. I'm using hand signals here, which doesn't work on the radio, but I talk with my hands, so I apologize. But they would use a freezing probe on the outside, and that would scar down the retina and reattach it to the wall of the eye. More recently, sometimes they'll still do scleral buckles, but they'll also do vitrectomy, maybe without a buckle now, and use the endo laser, where they actually have a fiber optic thing that's going inside the eye and putting laser. It's just phenomenal.
What they can do now.
Yeah,
It's just
yeah,
amazing.
Star Wars stuff.
Let's talk about. We're talking about peripheral. You were saying peripheral
Mhm.
laser, but peripheral vision loss is something that goes with what, and central vision loss that goes with what. But we're going to answer that question after we take this break, huh, Joan?
Very good. We'll be back. Hi, welcome back to Prairie Doc Radio. We've been listening to Dr. Ken Knudsen, who's an ophthalmologist in Brookings, and Dr. Holm discussing everything about the eye.
Yeah.
You talked about rods and cones.
Yeah, well, Bob brought up he was talking about night vision and rods and cones. Let's talk about rods and cones. Explain those, Ken.
Well, those are the two types of photoreceptors that make up the seeing part of the retina. There's actually layers to your retina, but the main important photoreceptors are rods and cones. Cones are the cells that see color and are used more for your fine central vision. And so histologically, or somebody looks at the physiology of the retina, they'll see more cones
In that
the central part, in the
the
macula.
macula.
Yeah, exactly. And you'll see more rods, which are the black and white, and actually are more sensitive to light, but they're more in the periphery. So that brings up the interesting point when people look at a faint light source like a star. You look right at it, sometimes you don't see it. You look slightly off of it, you start to see it, where there's more rods that are actually a little more sensitive to light and are used more for the night vision.
I have to say that I was laying in a hot tub. We finally bought a hot tub after 1,000 years.
Fun.
Looking at the sky, and I'm going, maybe it's my vision because of the things I've been having, but if I don't look at that cluster of stars, I'm looking at this tiny little cluster, which is a whole universe.
Right.
It's not a star. I mean, I'm looking at this, thousands and thousands. If I can see it, if I look away, if I look right at it, it goes away. Now, it amazes me that we do have color vision. I mean, it amazes me to think that we have vision. I mean, it's just,
Right.
if you think about the physiology of it all, and
That it
who
works so
designed
well.
this, and it works.
Mhm, yeah.
But now I know if we did the old color TV thing, there's a red and a green, and I mean, what is the color? How does that work?
Well, it's similar, the way I understand it. There's different types of cones that respond to different wavelengths, and it's the relative intensity of each cone, and your brain puts it together somehow that gives you color. So it's
And are there is the red
yeah, there's
receptors?
red, green.
Red.
You've heard of people who are red-green colorblind.
Yeah.
There's also, it's more rare, but somebody who may have problems with blues or yellows. And so somehow it all works and can give you, 1.6 million different colors. I don't know how it all works even myself, but it works.
It works.
Yeah.
One more reason to think about the design of it all.
Well, and then different animals have, as we know, have different vision than we have. So
right.
some are
Such
different colors than we see.
well, I mean, and that throws me back to the bat, who does have vision,
Mm-hmm.
but whose all his attention is spent on listening.
Echolocation.
Yeah, echolocation.
Well, and dolphins too. They can paint a picture in their minds based on the different return of sound waves off of solid objects.
Yeah, I was listening to a radio program about dolphins, and they were talking about the dolphin coming up, and the person was swimming, the reporter was swimming, and the dolphin was coming up and just kind of echolocating the person and looking at
Yeah.
her through the sound vision. I mean,
It's
you know,
amazing.
it's amazing.
The special senses.
It is a wonderful thing. So tell us about peripheral vision loss versus central vision loss, and what does that tell you?
Well, one is maybe associated with different types of diseases and the other with other diseases. So if we're talking peripheral vision, the main one we think of is glaucoma. If you're starting to lose nerve fibers in your retina from pressure problems, it usually starts with peripheral field loss, and you may be able to demonstrate that on a visual field test. And there's other diseases, genetic type diseases like retinitis pigmentosa, that affect maybe the peripheral vision first. Excuse me. And so you'll see some changes in the peripheral retina. And of course the big central one we talk about is macular degeneration.
Macula being the center of vision.
Right, just a term for the central retina where we have our fine central vision. And so that can affect the central retina. And there's some other diseases that can also affect that, diabetes, and some neurologic things that can affect the optic nerve, which might affect the central vision.
So I thought I had glaucoma nailed,
Mhm.
that I understood what glaucoma was going to be, and I thought it was all related to pressure,
Yeah.
and that it was because the drainage from the back of the eye to the front of the eye, where the
Mhm.
fluid escapes from the front chamber, occurs. And the more I started writing about it.
Yeah, I saw your newspaper article. I thought it was a good little article.
Did you thought it?
Yeah, because even the experts in glaucoma don't fully understand what's happening with glaucoma.
They don't, do they?
Because some people can have normal pressure and still have glaucoma type damage.
Yeah.
Usually it's a high pressure thing.
So, do you? And I was thinking about this, and I was waiting to ask you this. So I know that when I look through an ophthalmoscope, and that's a rough thing that I do, that is well tuned by you, but not well tuned by me. But I still do it, and I look through the eye, and I focus my vision on the back of the retina, and I look around until I find the disc, the cup.
Right, the optic nerve.
Where the nerve that gathers all of the messages from the retina comes together into a cable that goes back to the brain. And that cable, where all of the horse's hairs come together to the center and escape, which is not the macula, by the way. The macula is separate from that because that's a blind spot where that thing is. But with glaucoma, is it because you can see cupping that defines it as glaucoma?
Essentially, and that's one of the things we look at. If you think of the optic nerve, there's about 1.2 million nerve fibers coming from all the places of the retina to form the cable, as you
Right.
said. And as you start to loosen the nerve fibers, you look at the optic nerve where it's coming into the eye, you'll see a bigger and bigger cup. It's hard to explain without the visual, but if you think of a teacup, the optic nerve has a neuroretinal rim, and in the center there's kind of a more hollow area,
Right.
or a depression. As you start to lose fibers, you'll see a bigger and bigger area or cup, and that's one thing we look for to see, does this person maybe have glaucoma? Some
Right.
people can have a bigger cup and be normal, and some people, but in some people it's a sign of they're losing nerve fibers, and that's when we start doing some extra testing.
Right. Well, that's glaucoma, and that's more of a peripheral nerve loss.
Peripheral in advanced stages, though, people can go blind. If people remember Kirby Puckett, the Minnesota Twins baseball player, he didn't even know he had it till he got an injury, and they found out he wasn't seeing much out of the one eye. He had glaucoma.
I mean, you need two eyes to be able to see that ball coming
You
down.
would think so, for good depth perception.
Gee,
I'm
well,
curious on glaucoma. I do know that there's been great advances with cataract surgery. Are there advances in treatment of glaucoma as well?
There are, and there have been, and we keep coming out with new medicines, or drops are our main first line treatment, and that's been very good and has helped many people. But there's even new surgeries that can help get the pressure down. Filtering procedures are called, and there's been some that have been around for decades.
So
What about the herbal?
Oh, the
Herbal?
Of course, Bob would bring that up.
Herbal remedies.
Yes, as cannabis, which
Yeah.
Good job, Bob.
does lower intraocular pressure. I think it helps the uveal scleral drainage.
Oh, it does. So of course that's
It
the.
dilates the vessels, maybe because your eyes are red, right?
So they have much less glaucoma in Colorado. Is that what you're saying?
We'll have to see over maybe a few decades, but
If it makes a difference, huh?
yeah. Unfortunately, there's side effects with that
Yeah,
treatment.
So that's glaucoma. Now, what about macular degeneration? That's where you lose your central vision, and that's kind of like an aging process, isn't it?
Exactly.
I mean, we know everybody will get it if you live long enough, right?
Well, not everybody, but essentially you'll see aging changes back there, and even the name itself is ARMD, age-related macular degeneration. So,
But people who do whatever it is that makes aging happen faster, such as diabetes and smoking.
yeah,
Get
smoking
more-
definitely can accelerate it, and so if your eye doctor sees some macular back there and you're a smoker, he or she will counsel you to try to stop smoking.
Yeah.
It just affects everything, of course, smoking does.
Well, it accelerates the aging
It
process.
does, yeah. It puts stress on your cells, basically.
Yeah. yeah. But
Mhm.
we've got
We
more.
should probably take our last
Oh, we
break.
need a last break.
This is a great discussion. We'll be back right after these words. Hi, welcome back to Prairie Doc Radio. You've been listening to an interesting discussion of the eye with Dr. Knudsen, who's an ophthalmologist with the Brookings Health System's Yorkshire Eye Clinic. Before we mention any more on the eye, I've been reminded, tell people over and over again, this is flu shot season. Be sure to get a flu shot, right?
It is very safe, and it not only provides for your protection, a pretty good shot of protecting you from the flu, and not all colds, but the big bad one. But better yet, it helps you provide herd immunity for those who are immune deficient. And who are those? This is very elderly. It's people who get chemotherapy for cancer. It's young people. It's babies that
So
are
you're
very
saving
early.
more than just yourself.
You're looking after other people by doing this.
Okay.
I wanted to talk about tomorrow night. Again, we're going to have that show where we see Dr. Knudsen do surgery on me, and we're going to have Vance Thompson and Eric Thomas as guests for your calls and questions. And I strongly urge this to be an important calling in time. The other thing to say is that macular degeneration is commonly thought of as one of those deals where you can take herbs or spices or supplements or whatever to protect against it. What do you think is the thing that you can do to prevent macular degeneration?
Well, living healthy, of course, eating right, getting your fruits and vegetables certainly can help. Anything that protects with oxidative stress on our body. So
And-
we
and-
hear about antioxidants all the time. So
But I want to say that way more important than any
Herbal?
eye vitamins sold by Bausch and Lomb, or I mean, we still do it. A little bit of zinc, but the studies are real weak, and they show only mild change. The lifestyle change is what makes the difference.
I think that's your best bet in the long term, because once you see macular, yes, we have some studies that show maybe some benefit from slowing it down with some certain vitamins, and Eric tomorrow can talk more about that. He's a retinal specialist. But you're right, it's what can you do? There's no study or magic silver bullet. It's just taking care of yourself is your best for your overall health. Preventative things.
They're injecting back there. What is it?
Now that's with wet macular degeneration.
Uh-huh.
if you start to see some leaky blood vessels, there's some new medicines that help dry up these leaky blood vessels and can be used in wet. Usually you don't want to have the wet macular degeneration versus a dry, but there are some shots now that can help with the wet.
But they're expensive, and you have to do them or continuously.
Right, you may need one every month or every few months for a number of years, and certainly it's not bad, but it's not pleasant to have a shot in the eyes.
Dr. Knudsen, you mentioned lifestyle change would help with macular degeneration. Does it really make a difference if you exercise? Why does that help your eye? I
Well,
don't get it.
it's harder to explain, but it goes back to cardiovascular and vascular health probably, which Rick is more of an expert in, but it helps, not having strokes, your eyes not having any blood vessel problems there. Again, when you eat the right nutrients in a healthy, balanced diet, you'll have more antioxidants in there, which might help less stress on the photoreceptors.
So we can talk photoreceptors, we can talk strokes and heart attacks, and you can talk about all these pills and all these surgical interventions and blah, 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 but the truth is lifestyle is
Don't smoke.
Don't smoke.
way more important than all the rest
Exercise,
of it.
eat right. all that
Exercise.
helps.
Have I said exercise
I think
enough
you
today?
have. The other thing I'm curious, both of you know how often somebody should see an eye doctor. A lot of the audience listening is over 60. Much of our audience. Do we need to see an eye doctor every year? What do you think? What are the
Depends on what you have, but you should not go 5 to 10 years without seeing your eye doctor. If you haven't been in there, you need to get in there to check for glaucoma, and then look in the back of the eye, check for any macular changes, and then you can go from there. Probably for some people every couple years is fine. For others, every 6 months may be fine.
Or for me, every 2 weeks or a month.
It depends on your condition.
Okay.
I would say this though, that it's a great joy to have you here, and certainly glaucoma is a silent blindness causer, so don't miss out on checking for glaucoma.
The only way to pick it up is to have it tested.
Thank you so much, Ken.
Thank you.
Thanks, Joan. Thanks, everybody, and stay healthy out there, people.